Okay, great. Thanks very much, Simon. Hi, everybody. So basically, yes, so the first review on this topic was published in 2012. We had limited studies that were admissible at that stage. And since then, there's been a big growth in the number of studies coming out. So it seemed timely to do an update, and essentially we use similar methods to the last review. Because the performance-based financing is a complex intervention, we've tried to do a kind of greater range of analyses this time, including looking at different designs for performance-based financing, also looking at comparisons with a kind of business as usual as opposed to comparator interventions. And we've tried to distinguish in our analysis this time between the indicators which were targeted and those which weren't. And also to some extent drawing out results from the randomized controlled trials versus the other study designs. So there's a lot, it's a very long review, and we encourage you to look at the full review. I'm not going to be able to cover all of it today, but I'm just going to skim a little bit over it, hopefully as a taster. So in terms of the process, it's fairly usual process. So study selection, extraction, synthesis were done by two members of the group with an arbitration function and drawing from the QMU team and also the Cochrane EPOC group. We did the searches in 2018 and updated in 2020, looking at a range of databases, but also drawing quite heavily from grey literature and from institutional websites as for the last review and contacting experts. The study types which we included, again, fairly standard RCTs, control before and after, and interrupted time series, and looking at interventions that take place at different levels. So from a kind of government to government down to individual health worker incentives, and recognizing there's quite a lot of diversity within those, and I'll come back to that a bit more. In terms of the intervention types, we were interested in conditional cash payments, but also conditional payments of material goods and target payments. Most of the schemes, in fact, fell into the first category for those. And our main outcome indicators were, of course, health outcomes, also changes in utilization, unintended effects and changes in resource use. But we also had quite a wide range of secondary outcomes that we were interested in, which are linked to some extent to the kind of potential mechanisms and pathways. So in terms of data extraction, this was done by one reviewer using a structured form, and we extracted data on again, a wide range of domains reflecting the kind of complexity of these schemes, where you have to look at design at different sectors, sort of levels of funding, structures, incentives, verification, purchasing mechanisms, and so on. But of course also features of study design and study participants, and of course the outcome measures. So we then undertook a narrative synthesis. We were not able to do meta estimates because of the heterogeneity of the studies. And overall, we were trying to look really at the range of effects and make a judgment about the overall direction. And so we looked for indicators in the studies which were broadly comparable. One of our challenges was the range of different indicators used by the studies, a range of sort of definitions. So we looked for ones where there were at least two or more studies. And as I said, we tried to compare status quo, comparator interventions, but also whether indicators were targeted or not. And we then grouped them in clinical areas. And again, I'm not going to have time to go through all the detail of that, but I will give just some of the high-level results for those. So overall, we were looking at whether results were desirable, and that was generally whether they were consistently positive and an increase of over 5%. Whether they were neutral, and that was defined as under 5%. These are really for utilization. So for health outcomes, we had a more sort of generous interpretation. Undesirable being consistently negative and over 5% increase, and uncertain where either the quality or the effects were too varied to judge. And we have a very long summary table that provides a kind of overview using both bands. And of course, we looked at risk of bias using the grade tool. And generally, the results were, the quality was low or moderate. So just in terms of numbers of studies included, so we started from around 11,000, around 872, which were looked at in terms of full text screening. The main reason for exclusion was linked to study type. But you can see the sort of range here of reasons why studies were not included, including duplicates. And then at the end of that, we ended up with 59 studies which we included in the review. So the last review had 9, so you can see that that is quite a big increase in the body of literature. The largest group of study types were the control before and after, but you can see also that there's now a more substantial number of RCTs that were included. And the majority of them were looking at the effects of the intervention compared with standard care. And one of the challenges of that with performance-based financing is that there tends to be an incremental resourcing that the scheme brings in. And so obviously standard care doesn't allow you to see the extent to which the conditional element was effective versus the resourcing effect. But there were 13 studies where there was an enhanced financing control. So those are particularly interesting for that question. So a much bigger range of countries included this time, 25 countries, although there's the grouping in certain ones where a number of schemes and a number of studies have been undertaken. Generally, the settings are mixed, rural, urban, and there's a big focus on reproductive, maternal and child health services, and that's linked to some extent to the World Bank funding of a lot of the impact schemes, impact evaluations, and a trust fund which was focused on RMNCH. Most of the schemes are operating in an outpatient settings. So I'm zooming through all this. The bulk of them are supporting care in the public and not-for-profit facilities, so there's not very much engagement with the private sector at this stage. And in terms of the scale of intervention, it was quite variable, but the largest category here was studies that looked at a number of districts within a country. But 1 in 5 was describing a national rollout, so that's a fairly large scale. In terms of funding, it's also interesting to see that national governments and ministries was the largest category of funders, and that's in some ways reassuring from a sustainability perspective. The World Bank and the government of Norway are big funders in this area. And it's also interesting to look at the fact that many of the purchasing arrangements were integrated, and again that potentially indicates that these may be sustainable within national health financing architecture. So the number of indicators varied by scheme, but it was in the range of 8 to 12, commonly for the core kind of utilization or service delivery indicators. But there's often a very large number of quality indicators that are used to provide the quality scoring components, some of them more than 100. Of course, this makes it very hard from a systematic review perspective because there's a lot of data to potentially include. There's also challenges on what's reported. So as we say here, over half of the studies didn't explain how the indicators were chosen and set, which is a pretty important question for performance-based financing. We have some data on the magnitude of incentives, which again varies and reflects obviously the complexity of the service, as you would expect. But the relative magnitude is also important to understand its likely incentive effect, and many studies, more than half, don't report that. So I've just given some sort of bands here, mostly around 10% of health worker salaries from the studies that report it, but those are the minority, and it can vary enormously from 1 to 78%, so you can see the range there. We grouped the schemes according to different designs. I'm not going to go through these in detail, but obviously there is a big variety there, and we also have to bear that in mind when we look at the sort of overall findings. So some are focusing on individuals, some are combining with other elements like capitation, and one study was looking at aid. So the majority of the schemes are looking at payments per output, often with some modification according to quality and equity. And so that's all of the ones that fall into this slide. And then there's some, as I said, which use target payments. So you get paid only when you reach a certain threshold. But those can also operate as rewards or sanctions. So it's money that's added or it's money that's withheld, which from an expectation element will make a difference. As I said, overall certainty of evidence varies by indicator, but overall is still judged to be low to moderate. So just want to highlight a few messages to leave time for discussion. In terms of the utilisation and delivery of services generally, the effects are pretty inconsistent and they differ by indicator, and it's hard to find a kind of overarching trend. In terms of the health outcomes, they're not reported in very many studies, but there are some slight positive impacts where they are assessed against controls. When you look at it compared to the enhanced financing comparators, then those health outcome benefits are generally lost. In terms of quality of care, there's an increase in quality of care, but particularly focused on the kind of inputs to quality of care. So around, for example, medicines and equipment, but uncertain effects in terms of process quality. And where unintended effects are reported, we don't find any element of distortion. In terms of some of the more secondary outcome measures, generally pretty mixed picture. Health worker motivation, you might expect, would be quite an important channel of some mechanism of change, but in fact there's not very strong evidence of improved health worker motivation from these schemes. And in terms of governance, there's a little bit of a mixed picture in which autonomy seems to be increased in the studies that are testing for that, but limited evidence on the quality of management or governance, or limited evidence on improved quality of governance. And again, equity, not a kind of mixed picture generally, but particularly when we compare with the sort of adjusted controls. And for user fees, again, you might expect and you might hope, and in many schemes it's a condition that user fees are reduced for facilities to get performance-based financing, but in fact it's not often measured and the effects are not clear from the results that we have so far. As I said, we tried to look at different scheme designs, and in relation to the health outcomes, it looked as if from the few studies we have that performance-based contracting and results-based aid achieve better outcome effects. But when we looked at utilisation, the schemes that were kind of, if you like, had a complex design and which funded per output adjusted for quality and equity performed best. So it's a bit of a quick skate through all of that, and obviously it's important to highlight some of the limitations, not least the fact that we were having to try and look at comparable indicators, and that reduced the number of studies we could include. We would encourage, schemes to use a more harmonised set of service indicators in future, but also to report more consistently on absolute effects, which were not consistently reported on in the studies. Equally, ancillary components were not very well reported on, which we'd hope to look at more extensively. And there are a few other areas where we're suggesting more consistent reporting, including the theory of change behind the intervention, the cost of the programs, as I said, how the indicators and targets were set, and also the interaction with wider context changes. So some final reflections. Obviously, as I said, the evidence base has been growing, and that's very important, but it's also important to highlight some continuing gaps, and the aid modalities is one area where we're still not finding very robust studies. The evidence on longer term effects and cost effectiveness is also limited, and there's a need for more focus on health outcomes. It's also important to highlight the complexity of these different dimensions. So the interpretation of the findings is quite complicated. It's not easy to put simple summary messages for this review. And it's interesting to think about some of the possible mechanisms of change. And I think our review does shed some light on that, particularly this issue of additional financing. So when we take away the additional financing, we lose quite a lot of the effects. That suggests that resourcing is one of the channels of influence. But also this element of autonomy seems to be important, and the focus on providing inputs to quality of care. As I said, surprisingly little shift on some other indicators that we might have hoped to see change on. And I think the findings by different design type also suggest important areas for future focus. And we also recognise the need to look at heterogeneity within schemes. So many of these schemes studies are reporting on kind of average results, but looking at breakdown by different population groups, for example, and different facility types is really important. As a final point, I just want to highlight that there are many more studies in the pipeline. We've got 63 that are already awaiting classification, and so very happy to hear from people who are interested in joining the review team for the next update. So, leaving you with a link to the full review. Any questions or comments, happy to hear from you now. And also just to flag up that there is a very nice summary PDF which is available on the Cochrane website, as you can see on this final slide. So back to you, Simon.
Well, Sophie, thanks for that really fascinating presentation and covering so much ground in such a short time.